Thank you, and good afternoon, everyone. Thank you to the organizing committee for the invitation to be here today. So we'll be talking about the role of MiGs before filtering surgery, but before we do, we'll start with an audience response question. So finish this statement. My current view on the use of MiGs in normal tension glaucoma patients is A, I love MiGs and I use it all the time for NTG. B, I do a lot of MiGs for POAG, but only occasionally for NTG. C, I like MiGs, but never for NTG. D, I'm not a fan of MiGs in general, or E, what the heck is a MiGs? That was my wife's response too, by the way. All right, very good. So we have some MiGs users in this space. So slides. A couple of relevant financial disclosures. I am a consultant for a few MiGs device companies, New World Medical, Allergan, and Glaukos. Other relevant disclosures, though, is that I'm a self-proclaimed MiGs enthusiast. I perform most of these procedures on a weekly basis. I truly believe MiGs has revolutionized our treatment algorithms for glaucoma. It's also increased resident interest in the field, but most importantly, I feel like it's improved the lives of my patients. But I also believe there's a time and a place for everything. The question here is normal tension glaucoma the right place for MiGs? So as we know, normal tension glaucoma is a progressive optic neuropathy with all the characteristic optic nerve and visual field changes in POAG, but with an IOP consistently less than 21 millimeters of mercury. So this forces us to decide on very narrow therapeutic windows, often with treatment goals below 12 millimeters of mercury, sometimes even less than episcleral venous pressure. We know from the collaborative normal tension glaucoma treatment study that IOP does play a definitive role in the pathogenesis of this disease, such that the treatment group that had a 30% IOP reduction had a significantly less rate of visual field progression compared to controls. But if we look at how those patients achieved a 30% reduction, only 57% got there with the meds and laser available at that time. What happened to the other 43%? I think we all know. It's the procedure we love to hate, trabeculectomy. But we know it is effective at achieving that 30% rate of IOP reduction. It's also uniquely effective at getting to those single-digit pressure goals that we sometimes have. Schultz and colleagues found that almost 70% success rate at achieving a 30% reduction at 4 years after trabeculectomy in normal tension glaucoma. Iverson found that almost 90% did not progress after getting to that single-digit point after a trab. And Aoyama and colleagues found that almost 90%, even after a 20% reduction, had a stabilization of their visual field. But this all comes at a significant cost of complications and vision loss. We know from the TVT trial, the high rate of complications in the trabeculectomy group. These can be even higher, though, when we're targeting those single-digit pressures, particularly for hypotony, maculopathy, and related complications. And it's these very same complications that have spurred on the development of safer ways of lowering IOP, and that's where we get MiGs. There's 5 common clinical characteristics for MiGs: a small incision, obvious ab interno approach. They augment physiologic inflow and outflow pathways. They have at least modest IOP efficacy, but with a very high safety profile. And this enables our patients to recover their vision and with very little downtime quickly. So it's often paired at the time of cataract surgery to not only lower pressure, but also reduce medication burden. And now we have a variety of approaches. There's angle-based approaches with goniotomy and trabeculotomy using a number of different devices. We have 2 trabecular mesh bypass stents on the market, canaloplasty, cycloablative procedures with ECP and even micropulse, and I would throw in subconjunctival procedures now with the Zengel stent, which can achieve filtering surgery from a minimally invasive ab interno fashion. So if we want to look at how MiGs can perform in the NTG population, we should look at the data first, right? So if we go to PubMed, you type in normal tension glaucoma and MiGs, it's going to return a whopping 0 results. But that doesn't mean we can't use the published literature for other populations in MiGs to see what type of IOP lowering we may be able to achieve in this population. If we look at our own outcomes in Colorado from phaco iStent, with the group of patients with a fairly low starting preoperative IOP of only 14.7, this is medicated pressure, you see we have a significant drop in pressure and medications, but only a 1.5 points, bottoming out at 13 millimeters of mercury. Ray Brown and colleagues also investigated the relationship between preoperative IOP and the amount of IOP reduction you can get after phaco iStent. You can see if you stratify by pre-op IOP, the greater than 21 millimeter group had a 7.5 point reduction in pressure. But if you look at the group that started out less than 15, only a 0.1 millimeter reduction on average in these patients. If we look at goniotomy, another angle-based procedure, both in combination with cataract surgery and as a standalone, again, starting from a pressure less than 21, we see a significant drop in pressure and medications, but again, we see it bottom out at around 13 millimeters of mercury. If we go subconjunctival route with the Zengel stent, now we theoretically can get to those single-digit pressures, but if you look at the average from this very large study from Karimi and colleagues, you really only got below 10 on day 1 and week 1. On average, they, again, evened out at about that 13 millimeter of mercury level with a significant reduction in medications. So when should you consider MIGs in normal tension glaucoma? I think in general in the more mild to moderate disease, but it really depends on what your treatment goal is. If you're just trying to maintain a pressure level where it's at and reduce medication levels, this is a great opportunity, or if your pressure goal is above that 10 to 12 mark. If they have a coexisting cataract that's visually significant, this is an excellent opportunity to employ a MIGs at the same time. We also know that almost 80% of cataracts are going to progress after a trabeculectomy, so addressing it first may be beneficial, and that cataract surgery after a trab can lead to fibrosis or failure. And then those patients who are at high risk for filtration surgery, like your high myopes, the monocular patients, and then those who may have had prior complications from a previous trabeculectomy. When should you not consider MIGs? Well, if you're going for a single-digit pressure, these are not the procedures for you. Particularly in those advanced patients, if you're approaching fixation, there's also a risk of IOP spike after MIGs. So at worst, you could be causing harm, and at best, you may be losing ground while you're delaying the definitive therapy. These are the patients that still need to go on for trabeculectomy. So going back to our original question, does MIGs have a role in NTG? I think the answer is yes, but it has its limitations, no doubt. And trabeculectomy is still the gold standard for this disease surgically. It's effective at achieving 30% reduction or more, but specifically those low IOP goals, less than 10, all with a significant risk of complications and prolonged recovery. MIGs offers several safer alternatives, that's clear, but there's very limited data supporting its use in this patient population. I think it's most useful whenever our goal is to just reduce medication burden or our pressure treatment goals are greater than 12 millimeters of mercury. Thank you.